his master's in general surgery from one of the prestigious institute, PGIMER, that is Postgraduate Institute of Medical Education and Research, Chandigarh in 1994. Dr. Harinath Garu did FRCS in 1997 and FRCS General Surgery in 2005. Dr. Harinath completed his research on rectal cancer and awarded with MPhil degree from South Glamorgan University, South Wales, UK. Dr. Harinath has completed higher surgical training in South Wales in 2006. Dr. Harinath Garu has been working in UK since 1996, and his areas of interest are general pediatric surgery, colorectal surgery, colonoscopy, hernias, coloproctology, bowel disease, including inflammatory IBD, endoscopic procedures like gallbladder diseases such as gallstones, etc. He has special interest in diagnostic and therapeutic colonoscopy and robotic surgery. Dr. Harinath has published a number of papers having national and international reputation, and also he has participated and presented papers in a number of national and international conferences. Really, sir, I feel it a great privilege to invite you to deliver your talk on surgical practice during COVID-19 pandemic, strategies for prevention and practice. I welcome you once again, sir.
Thank you, Dr. Vijay Kumari. Thank you. Thank you, everyone, for attending the webinar. It's my pleasure to be part of this webinar. Can I just confirm that I'm audible?
Audible.
Am I clear? Am I audible?
Okay, sir.
Yes,
Thank you.
Yes, sir.
Right.
Yes,
Thank you so much. Good afternoon, everyone. Thank you for the nice introduction. You already heard very nice presentations, which are of high profile, previously from both Dr. Reddy and Dr. Naidu. My presentation is very, very simple, and mine is very practical. I don't deal with any molecules, RNA, DNA, or proteins. Mine is a very practical based presentation. I'd like to thank Professor Bharathi for giving me the opportunity to talk on the surgical issues relevant to the current global pandemic. I'm really grateful for the invitation. And when it comes to surgery, the most important thing that comes to my mind is prevention of the coronavirus. So I'll focus on what our practice is at the moment in our institution to prevent coronavirus. And my presentation will be, I'm just going to share my slides. My presentation will be on a brief introduction on the current problem with its impacts in general, and also on the NHS and healthcare systems with new normality that we're going to face in the months to come. And also, I'll be talking about preventative practices that we are currently following in my institution. That would be preoperative, intraoperative, and postoperative practices to help ourselves safe. And the recommendations are mainly from the great organizations in the world. And mine is simple presentation, as I said before, and the principles are related to general surgery. I'm pretty sure the principles are also applicable to other specialties, although with slight modifications in other specialties. So I won't touch base on other specialties. There are a few limitations to my presentation. I won't be talking on a lot of things that's been already covered in the previous presentations. That includes diagnosis, management of COVID-19, vaccines, any specific treatment, and epidemiological aspects, how this spreads and so on. all this has been covered in the previous presentations. And in particular, I'm not going to talk about any controversies that's going around on the virus, which of course grabs the attention of newspapers very quickly in the media. Right, introduction. As you all heard, over 20 million cases have been reported already and still counting. However, it is a bit static in some countries, and some countries even declared that they are corona-free, leading to release of lockdowns. And that's led to further increase in the cases. Over 750,000 deaths nearly have been reported throughout the world. And this has caused so much of social disruption, havoc, economic impact, leading to collapse of economies throughout the world. In the UK alone, there were 46,000 deaths. That's been downgraded last night to 41,000 because the way the deaths reported is different in different countries. Depends on what criteria you use. In the UK, we use deaths within 28 days with corona positive test. There could be other coincidental factors. Based on that, 41,177 deaths have been reported so far. And in India, as you know, there are 23 lakh cases with 46,000 or 47,177. That's the latest from this morning. This is the highest, third highest in the world after US and Brazil. I'm not going to underestimate how many healthcare workers have been affected. Over 1 million people have been infected, and we don't really know how many deaths have happened among healthcare practitioners. And as you already seen and witnessed and been affected, maybe one way or the other, so many areas of our daily life has been affected. Health, politics changed, education, kids' studies have been affected, social norms have changed, traveling industry is completely collapsed, the food industry is different, tourism is completely gone, and you will see every single business is affected in this world, and everyone is affected. And we don't know the real consequences. And we're going to uncover more and more as time goes by. Similarly, the NHS in the UK, which is National Health Service, which is one of the fantastic organizations in the world, which is free for everyone, is affected. So the immediate changes we noticed straight away are elective surgical practices have been cancelled to allow for COVID cases to be treated. And that included all the standard cases you see, hernias, gallbladders, and so on. And there have been lots of guidance that have been issued straight away overnight from various organizations, including Royal College of Surgeons, Association of Surgeons, and so on. And this is to allow for COVID patients to treat, and that would give space for these patients to be looked after, maybe in the wards, or maybe it's in the ITU or HTU facilities. And there are massive structural alterations within the hospital, again, increasing the opportunities for looking after these patients. Wards have been converted into COVID treatment areas. And as you already heard, in China, they built the hospital in 10 days. Similarly, in England, they started to build Nightingale Hospital within a week. So you will see changes, and that's what is necessary to look after the COVID patients. Only emergencies, which means life-saving procedures, were allowed, and that would include standard bowel obstructions, perforation, peritonitis, and so on. Even cancers cases have been stopped initially. Now that's subsequently, a few weeks down the line, there's been some guidance, and then we're beginning to do the cancer cases. As I said, all elective cases cancelled indefinitely. And as I said, in ITU, HTU facilities everywhere, they started to come up with lots and lots and lots of changes. I can't really go through all those details, innumerable thousands of changes. And there have been recommendations pouring all over the world from various societies, Royal College of Surgeons, health departments, government agencies. And these guidelines and recommendations have been produced from all these societies. And this is to mainly address what the surgical practice should be. And this is mainly to look after patients, improve the safety, and stay safe for the healthcare professional point of view. Just briefly, I want to talk about the levels of evidence that we use in medicine. I'm pretty sure it's used in other areas as well. If you look at the top of the pyramid, where the cutting edge technology, all the new treatments have been tried and tested through randomized control trials, systematic analysis, and so on. And that forms the guidelines mostly for clinical practice. And that is the current standard. As we see more and more research, high quality research, you're going to see more and more guidelines coming up from these societies. At the very base is the case reports, expert opinions. That's got a less of an impact in any journal. That means it's not likely to influence any treatment decisions. However, all the guidelines, recommendations that's been coming up from various societies, big institutions, government agencies, all coming from through this expert opinion. So this is basically level 5 evidence, and that's what we are doing. Of course, all these guidelines make sense. These guidelines and recommendations are to protect patients and to keep the healthcare staff not infected by the virus. Therefore, the guidance is that all surgical procedures, elective procedures, should be postponed indefinitely. And that's to allow, as I said before, COVID patients to be treated. Because if you are practicing elective surgical procedures, you are going to see some complications which will demand HTU, ITU care. In particular, my specialty, the colorectal specialty, where you get up to 10% of patients get complications. And those complications can be quite life-threatening, which means you need to be able to look after these patients in the intensive care facilities. That means they'll be competing for the intensive care beds. Then obviously you're limiting your opportunities to look after patients who would require the basic things, which is like an oxygen or ventilation and so on. Second guidance is a non-essential hospital staff, office staff should be allowed to stay at home, and if possible, should be able to work from home. And that is to make sure that the social contact is minimized, and that obviously will reduce the chance of infection, and that would allow some of the online duties and procedures that they could do. And that's what's happening, because social distancing is really important. And in fact, at the beginning of lockdown, everybody was asked to stay at home. That was one of the advices from the government: stay at home, do not go to workplace. That means if possible, you work from home, otherwise you don't work. The third advice is non-urgent visits, office visits, like clinic visits, should be cancelled. So that's again reducing the opportunity for infections to spread. And all the meetings, including multidisciplinary meetings, audit meetings, mortality morbidity meetings, teaching sessions, all of them needs to be stopped face to face, which is what happens in the NHS on a routine basis. All that's been changed to online video meetings. All these changes make sense, but this is all not based on, as I said, top level of evidence. Is based on the expert advice. Of course, it's not possible to do any randomized control trials to make any conclusions. However, we noticed that these measures seem to be working for us. And the recommendations, there are lots of recommendations have come up in my area where endoscopy is such an important adjunct for diagnostics and treatment, without which we will not be able to manage. There are guidelines as well. We would operate on any age patient, it doesn't matter, as long as they're fit and healthy. And the endoscopy is such a crucial specialty for us, and general surgeons, and in particular gastrointestinal surgeons, cannot survive without any endoscopic facilities. Unfortunately, endoscopy is an aerosol generating procedure. As you already seen in the previous presentations, a sneeze or a cough can generate aerosol that can travel a few meters. So similarly, endoscopy is an aerosol generating procedure, which means it increases the risk of infections to endoscopists, all the staff. So therefore, the advice is that they all should be wearing special masks, which we never did before, and they are called FFP3 masks. All the emergency procedures that are carried out through endoscopy are also very high risk because it does involve using high energy devices like diathermy and so on. And that means your risk is higher. And unfortunately, other organs are also affected by COVID, not only respiratory system. In the gastrointestinal tract, saliva, enteric contents, stool, all of them have been shown to have virus. Of course, blood is not excluded. So that means transmission can happen even through blood. So when we are using any energy devices, it should be minimized. But obviously, if you are doing a complex endoscopic procedure, your limitations are quite high. You will probably fail or end up using a lot of energy devices to control the surgical procedure, and thus increasing the risk of COVID. And in particular, special procedures like endoscopic mucosal resection and any therapeutic procedures we do increases the risk. And the equipment needs to be sterilized separately compared to other patients who do not have COVID virus. And there are guidelines for laparoscopy. As you probably have heard or seen in the internet, most of the modern surgery is laparoscopic. We are heading towards robotics in the future, which means minimal approach, smaller incisions, which reduce the risk of infections. And the guidance is avoid laparoscopic surgery because this is aerosol generating procedure. And if you are going to do it, you should have a special smoke extractors. You need to make smaller incisions so that when you put the ports inside the abdomen, there won't be any leakage of gas, which is carbon dioxide. Incisions should be small, and the carbon dioxide we use for insufflating the abdomen, you can't use it at higher pressure. Depending on the body weight, you may have to use higher pressure, or depending on the procedure, higher pressure may be necessary. We have lots of obese patients, and that's of course a modern phenomenon. It's happening throughout the world in developed countries. Obesity is very common. A third of people in the UK are overweight or obese. So the recommendation is you should try and use minimal pressure, which is 8 millimeters of mercury, which is very, very difficult to do. Standard pressure is usually between 10 to 12, but if you are obese, you may end up using even up to 20 millimeters temporarily. Once the laparoscopic procedure is completed, You need to make sure that all the pneumoperitoneum, which is the carbon dioxide inside the abdomen, needs to be extracted very carefully so that the leakage doesn't happen into the theater space. And this is again to reduce the contamination. The measures for surgery. We should always discuss the possible exposure of the virus to the patients. While you're in the hospital, you may acquire so many infections. Chest infections are common, Clostridium difficile, or even some viruses and other bacteria can be transmitted to patients. And some virus can be transmitted even through the blood, like hepatitis C and hepatitis B and HIV and so on. So we always screen the patients. So we need to talk about the consent, that there's a high risk of infection, and the chance is probably 0.5% if you're carrying out a major procedure. And once you acquire COVID, then you got 30% mortality. Anyone who has COVID don't operate, of course. Obviously, we need to treat them. When you intubate, which is putting a tube through the respiratory passages to anesthetize, that's a very high risk procedure and should be carried out in a negative pressure room. And theaters to be appropriately ventilated, aerated, and so on. There should be appropriate filters. Only essential staff should be available, should be present. Electrosurgery, as I said before, diathermy is part and parcel of a modern surgery. Without diathermy, no surgeon can survive in the modern world, modern surgical procedures. And there are other devices coming up, which is called ultrasonic dissectors, which is harmonic scalpel, and ligature, and so on. All these devices are really important for looking after our patients safely. And they all generate high levels of aerosol, plumes, and risk of infection is very high. Surgical equipment, of course, needs to be sterilized as well. But once you operate on people who got COVID, you need to sterilize them separately. This is a brief summary of the guidelines that's come from SAGES, which is one of the big organizations. This is European Association of Endoscopic Surgeons. So basically they're saying minimum number of theater staff, all staff should wear PPE, which is very expensive, of course. Service rationalization, which we talked about, postpone all cases, minimize face-to-face consultations, virtual MDTs, and again, laparoscopy. We are doing too much because we don't have any evidence that it can be transmitted through the laparoscope. However, based on the previous studies on the smoke containing viral particles, we believe that potentially even COVID can be transmitted. But we don't have any proof so far, and there's no reported case in the world yet. And there are benefits, of course. Laparoscopy, as I said, this is the modern surgical procedure. We have to offer laparoscopic surgery, and we need to use energy devices and very minimally, and the carbon dioxide and smoke that comes out after laparoscopic surgery should be extracted. And the consent, we need to cover the COVID-19 risk, and all patients should be tested prior to surgery. And we should have a dedicated theater for COVID patients only. And as I said, for endoscopy, all staff should wear personal protective equipment, which includes PPE. And for all advanced procedures, try and avoid them for the time being. That's the guideline that's come from these big societies. And there are a lot of other guidelines that have come up. So there's immediate impact that we notice. We stop laparoscopic surgery. We see no staff around. Straight away, we could see very, very few people around immediately. We changed the consent forms based on Royal College of Surgeons recommendations. More leaflets came, more paperwork, of course, and all face-to-face consultations have been stopped. And that means we have to talk to patients only on the phone about their symptoms, and even explain what operation we're going to do, and so on. And of course, there's huge governance issues related to telephone consultations, video consultations. how we're going to conduct and so on, what should be the guidelines. They all have been produced immediately. And all trainees, we could see the trainees have been diverted to HTU, ITU, and medical ward areas, because where you got HTU, ITU facilities, the doctors could not work longer than more than 4 to 6 hours, because it's so difficult to wear the personal protective equipment, and they could not have breaks, natural breaks, including not even a drop of water for sometimes up to 8 hours. It's very difficult in the ITU setting. And that left a very bare minimum staff for our emergency services and cancer-related work. And we were relying more on the telephone we don't even see how the patient looks like, and you've got to talk to them about what operation you're going to do. That's very hard. And all our meetings, including governance meetings, mortality, morbidity meetings, all became online WebEx services. And training has been stopped. So we had a training guideline that's come up from various deaneries to stop the training. No education at all, no surgical training, no teaching, no ward rounds teaching, no grand rounds, everything has been stopped. Which is, of course, England is a place where you get fantastic medical education. And that includes grand rounds and so on. Unfortunately, these have been stopped straight away. The mortality morbidity meetings, of course, this is what we do as a governance in our department. We talk about all the complications that happens, including deaths. We got to talk about and learn from these meetings, and they have been stopped. Masks became a must later, which of course initially it was. The masks became normal. Contact with juniors became very, very bare minimum. And some doctors became even ill with COVID. And that led to more problems. And some became ill because of other reasons. Until they've been tested, you can't come to work. So the testing facilities initially was quite patchy. Of course, now we've got testing facilities exuberantly. And there are a lot of other adaptations that we had to do. All rooms, every single room in the hospital has been earmarked with maximum number of people. So you don't breach that. No shaking hands, of course. Alcohol sanitization everywhere. You could see people going to the sink, washing their hands more often. Social contact reduced. You can't see your own colleagues and friends. And we became more paranoid, more alert, and more mindful of what we've been doing. And not touching anything while you're walking. For example, when you walk along, sometimes people do touch objects like railings and so on. So you became more paranoid. So, and also, as you can see in the previous presentation, there are some high-risk people. So it could be one of the doctors or one of the healthcare professionals, like nurse, could be in the high risk, for example, diabetes and so on. So they are all at a higher risk of acquiring COVID. And as you can see, loads of guidelines have come up from these colleges, which is the NICE guidelines, which is National Institute of Clinical Excellence. And there are hundreds of international guidelines from various countries. This is all, as I said, too much. There are association guidelines, Association of Coloproctology, Association of Surgeons guidelines. I'm pretty sure all associations have produced their own guidelines to look after their staff. And as of last night, there were 42,973 publications in the last 3 months. That's far too much on COVID. And it's difficult for any clinician to go through all that. And it's too confusing as well, because the evidence, what we've been seeing is all of that is case reports, more and more case reports, more and more guidelines, more and more opinions. They're all basically the level 5 evidence. Which guidelines you're going to follow? American, European, or British, or Indian? We don't know. So it is too confusing, too much, and don't know what to do. A lot of people, there's too much information to digest. It's too confusing, as I said, and it may not be applicable to all circumstances. It may not be applicable to India or other countries, for example. As I said, this is information overload, and that means you're going to give up, basically. And it's all happening too quickly. And as we speak, I'm pretty sure there are more and more papers being published before our webinar is finished, and more webinars as well. Of course, you don't know which one to listen to, and they're all free, of course, but still, I don't know which one to rely on. So I'm going to talk about preoperative practices that we changed, including donning and the surgical principles, doffing, which is how you're going to remove all your surgical gowns and adjuncts, and the postoperative practices we've been following with all the guidance we've received from various societies. So as I said, we stopped doing the standard clinics. So preoperative practices based on telephone clinics, which means you have to talk to them on the phone, you have to take the history, and as I said, in Britain, there are a lot of elderly people. There are a lot of people who have got other comorbidities, including dementia, those who can't hear properly. You've got challenges on how we're going to connect with people to achieve and complete your telephone consultations. And that led to more issues on how we're going to solve these patients' problems. Then we started video clinics. Again, there needs to be some governance on how we're going to conduct the video consultations with your patients, because you need to have some guidance. Otherwise, there could be a scope for errors or misuse and so on. So we started video clinics, and we started relying more on CT scans. So CT scan is a scan which tells you if there's any lump in abdomen, for example. We're relying more on it. Previously, we were relying on other investigations like endoscopy, which is not possible now. So we started relying more on CT scans. Endoscopes has been stopped overnight, and we were doing only emergency GR bleeds and so on. So we had to just go by CT scan findings. We offered operations based on CT scan findings. And we had to counsel the patients on the phone. How on earth are you going to explain to patients that there's a mortality of 20%, and if you get COVID, you get 30%, and patients have to believe you, trust you, and agree for an operation. So we started to do some face-to-face consultations on very frail, demented patients, those who got disabilities and so on. And as I said, WebEx digital meetings started on the cancer meetings, agri-patient management. All this is to limit the contact. So we've actually followed the guidelines. All these guidelines, as I said, they all talk about the same. All these guidelines from various societies are same, almost really, to cover the principles to protect patients and protect the healthcare staff. And the consent forms changed. Minimum contact, as I said. Isolation 2 weeks before surgery. So you cannot operate on anyone unless they have been isolated for 2 weeks. That means nobody comes to the patient's home. They don't go anywhere. All the food, shopping, everything needs to be online, and so on. Of course, this guidance is being reviewed again. We're hoping that this will come to less than a week or even 3 days. And everybody would need a COVID swab. Of course, this needs to be completed and reported well before surgery. And if you don't have COVID swab test result, we wouldn't operate because they could be positive potentially. And that means they really got 30% chance of dying. And that also, this meant that we had to give more instructions to the family and then more communication through various team members, in addition to the usual practices that we would normally carry out. And obviously, the video consultations are not suitable for everyone. And we ended up seeing more and more face-to-face with following the social guidance, 2 meters guidance and so on. Donning. You all probably have seen how surgeons wear the gloves or whatever masks they wear and so on. In the new recommendations, we've been advised to use special masks, which are quite different. They cause a lot of suffocation and retain heat on your face, and they even leave stretch marks, or even cause some abrasions on the face. And that's what we're supposed to do. And all our 6,000 staff in our hospital have been fit tested. So they needed to be tested to see which mask is appropriate. And that includes FFP3, FFP2, and N95 masks and so on. Unless you're fit tested and you have a certificate, you don't really wear any mask randomly because you may still not be protected. That's the problem. And there are specific areas that we have to follow the donning. We have to, of course, watch some videos to understand how the donning is done in that sequence. Otherwise, you may think that you're protected with all these new gadgets. You are not protected. And other protective measures include a double gloving, water impervious gowns, extra long and extra thick means you're going to be hotter inside. It's more uncomfortable. The visors and goggles, of course, they would cause more fogging and you can't see the operating field easily. And it's all more problems because it does add more challenges to your surgical techniques because laparoscopy is being stopped and we started doing open surgery, which means long incisions, which we stopped. Of course, I've been practicing from 1990. From 2005 onwards, we've been doing laparoscopy more often. And from 2008, I've been doing laparoscopic colorectal. For last 12, 13 years, laparoscopic surgery only. And that means we are losing the open surgical skills. And all of a sudden, we had to do all those new procedures, although it's the same old procedures, but we had to start doing the open procedures. And I remember when my boss in PGI did a first laparoscopic cholecystectomy, there were nearly 50 postgraduate students all around watching how the boss was doing the laparoscopic cholecystectomy. Well, the new norm, of course, as I said, is a minimum staff. Only my assistant, and that's it. And maybe a scrub nurse. So that's to minimize the number of staff. We're still not doing laparoscopic surgery, of course, because smoke extractors are not available. Of course, there are some centers doing this, which is quite difficult to do without laparoscopic surgery because doing pelvic operations, bowel cancers, especially in male pelvis, is quite hard. And sometimes they last all day. It's quite hard to sustain all day operations, so we have to take breaks and so on. And as I said before, energy devices have changed, so you can't use laparoscopy instruments anymore. That means you have to use the standard surgical equipment. We have to use low diathermy settings, which is quite tedious in terms of controlling the bleeding. And we have to use more suction devices and so on. And we have to cause minimum blood loss. Of course, open surgical procedures always cause more blood loss. For a standard bowel cancer operation, you may lose up to 500 mils for open surgery, as against 20 mils. I've done with the 10 mils of laparoscopically. And of course, if you have a minimum blood loss, there's a minimum contamination, and therefore the need for blood products transfusion is much less, which is good for the patients. And we have to stop washing the abdominal cavity because that's again increases the risk of COVID and so on. Brief word about laparoscopic surgery. Is very well established throughout the world. Of course, there are lots of benefits for surgeons, patients, institutions, organizations, and so on. With COVID-19, we've stopped it, and the basis for stopping is that smoke could potentially have the virus. Of course, that's been shown previously with the human papillomavirus and also with other viruses like HIV. Not been shown with COVID yet, and that is what the predictions are, that smoke, plumes, aerosol from laparoscopic procedures could potentially contain COVID virus, and that surgeons and healthcare staff could acquire. And this is the smoke extractor, which filters all the bacteria known to humans. And that's what we need to start the procedure. Again, there are no randomized trials to show that this is definitely required. Of course, it's a common sense. It makes perfect sense to use this to absorb all the aerosol plumes, and the visibility is much better, of course. And the doffing. Once you complete the surgical procedures, you have to remove gloves, gown, and various other things you've been wearing for hours together. And of course, there's a special technique. Again, we have to watch the videos. In that sequence, you have to remove, otherwise you could potentially catch the virus. So you have to watch the technique, and there are special areas to doff, and there are some special facilities again to destroy the infectious waste, and there's videos available to complete that. So again, doffing had to be mastered like donning. And after you looked after the patient intraoperatively, postoperatively, you can't just go and see the patient as and when you want. You had to have special masks again to go and see the patients. Standard wardrooms have been replaced. Not many people would go and see the patient. You would have to go with very bare minimum stuff to go and see the patient. We had in our department, one surgeon would see all patients. That means other surgeons could be rested, or they are not exposed to the risk. And everybody had to wear gloves, masks, and plastic aprons, even clean patients. Of course, surgical procedures do come with drains, tubes in the nose, where there's a risk of splash and so on. And patients may even cough sometimes on you. Or you may ask the patient to cough, for example. All those situations, you need to be able to protect yourself. And of course, no visitors at all. So once the patient's been dropped in the front door, they have their surgery, and the families would come only to pick up their relatives. And if they die, and they won't even get their dead body. Obviously, this is secondary to COVID, of course. And again, once they're discharged from the hospital, they have to follow 2 weeks of isolation. And they're always followed with mostly the telephone follow-ups. Without the general measures that the hospital is introduced, no surgical procedure or any medical treatment is possible to carry out safely. So every single person would come through only one door. That means all other routes have been closed. And every single person, they will all be in the queue. They will have to have their checks on the temperature. Everybody had to have all-call sanitization. And the exits are also controlled. Nobody can just randomly go away in the way they want. And lots of signposting came up, lots of communication posters, and obviously the traffic management. So you can't just go wherever you want in the corridors. You have to, like a driving system, you got to walk on the left-hand side rather than randomly, so that you don't bump into someone. And the color coding, of course, the wards were color coded. Those with COVID, interestingly, the COVID wards were coded as blue, and the clean wards were coded as red, contrary to what one would think. And surprisingly, there was so much support from the industry nearby. All the surgical staff being looked after with lunches, snacks, water for free. Of course, the hospital started providing as well, because this is one of the areas where gatherings happen in the canteens and other places where the risk of contamination is high. So you heard about the new norms that we've been practicing. Is this forever is the next question. How long we have to practice this? So all the precautions, measures that we've been following is to keep the patients safe, and of course, health staff free, so that we can continue to provide the service. Otherwise, patients are going to die, and lots of mortalities will happen in the society. And of course, this is to stop the nosocomial infections, which is hospital-acquired infections. You heard about the vaccines that are likely to come up. We don't know when they're going to come up. I'm not going to talk about it. Of course, that's going to influence how we're going to practice as well. So there is a role for the vaccines to influence our way of surgical practice. And we're expecting a second peak in the winter months, which is going to come in next 2-3 months, we're expecting 120,000 deaths, excess deaths, as against the standard. Of course, we're all prepared for the second peak. Therefore, in the short term, is likely to stay with us. In the foreseeable future, I would say, we're all prepared for the new norm as long as is necessary. So those who are already practicing very good preventative practices, please follow standard practice that seems to be working for you. Try and cut down the corners, avoid variations, deviations to your practices, look out for the improvisations and see where there could be improvements in the practices to prevent virus spread. Don't experiment because all these experiments are done by people who are done in desperation. That may be doffing, that may be carrying out surgery without following the principles. So don't break the norms and new standards. Follow local practice. What seems to be working locally in each hospital should be practiced. And there should be some vigilance, some governance among the clinicians themselves. There should be some leadership. Keep fit and up to date. That's of course applicable to all of us. Ignorance is not bliss anymore. It is dangerous. So you need to be up to date with what's going on around you. You cannot be complacent. You cannot be ignorant. New ideas, innovations may work. Watch the space. You're going to see more and more guidance, more innovations. So keep your eyes open, ears open. Otherwise, you're going to miss out. And you have to take the responsibility for yourself. Of course, that's for every single citizen and for their family members, of course. No doubt, more audits, research is awaited, which is going to change our guidelines and practices. Probably not hugely, in my opinion, but I'm sure there will be more guidance and more treatments, of course. So do we have a choice? For example, this pandemic is happening. There are lots and lots of advice coming up, and we have a choice. Do we have a choice, or do we break the rules? I feel that there's no choice. We have to learn. We have to adapt to the new circumstances. We need to improvise, innovate, and be responsive to our society and be proactive in adopting to the new requirements. And this is the only way we are going to be successful against the virus. So in summary, we're almost there now. Thank you for being very patient. In summary, more than 20 million people are affected. Of course, this number is changing all the time. And there's a huge impact throughout the world. And 750,000 people have died so far. Health sector, of course, is no less affected, like any other specialty or any other business or any other person. Everybody had to make changes. Everybody had to adopt. Otherwise, we're going to fail. We're going to let the virus progress, and this is going to be even more disastrous. Surgical procedures, of course, is a high risk. And we talked about the surgical precautions and practice measures. And of course, without the help of other specialties and other agencies, multi-pronged approach is necessary to stay safe. I'm going to let you read this. So I would think we all should be more responsive to change rather than, well, be intelligent and strong as well, of course. We have to be responsive, as Charles Darwin said a long time ago. Thank you very much, everyone. And I would like to thank Professor Bharati and Padmavati Mahila University for giving me the opportunity to talk and share my views and our practice that's happening in the UK with you. I hope you find this useful and be safe, please. Stay safe and look after yourselves and your family members. Thank you.
Thank you very much, sir. for your very informative and excellent talk. You have covered various aspects like what are the preventive and practices, and also post-operative care, and various minimal invasive procedures, and various recommendations made for the healthcare professionals. Thank you very much, sir.
Thank you.
So there are no questions from the delegates. Sir, I
Either-
have a small query.
Okay, go on,
Sir,
please.
will you please explain the difference between different masks, N95, FP3, P2?
Yes, these masks are basically, as you have probably seen in the net, or people
Yes,
wear,
sir.
they all have a different pore size. So there's multi-layers and pore size,
Okay.
and depending
Okay.
on which mask you're using, the viral particles are trapped in the mask. And this is what Dr. Reddy was saying, microbiologist was saying. The masks are also at risk. So if you leave it for a longer time, if you use the same mask, you could be infecting yourself from the mask, which is filtering all the viral particles. So it's basically filtration ability. Depending on where you are in terms of your work setting, either in the endoscopy theater or a clinic, ITU, you need a different kind of masks. That's been recommended, of course. A standard mask won't protect you. So there are different types of masks based on the pore size and the fitting, and that's been recommended for different kind of settings. That's all.
Thank you, sir. Thank you very much. Bharti ma'am. Bharti ma'am.
Thanks, madam.
Bharti ma'am.
థ్యాంక్స్ చెప్పావమ్మా సార్కి చెప్పిందా థ్యాంక్స్
Yes, ma'am.
థ్యాంక్స్ ఓకే థ్యాంక్ యూ for the excellent and vast information on surgical practice during COVID-19 pandemic, strategy for prevention and practice. Questions questions also finished. Chat box.
No, ma'am.
Okay.
Leave, ma'am. Em leave.
Okay. Thank you, Vijay Kumari. Good evening to everyone.
Thank you, Professor Bharati, and thank you, Dr. Vijay Kumari.
Sciences and Sericulture. I feel a great
And stay safe. God bless you all.
resource persons of today. Professor D. Samba Reddy Garu from Texas, USA. Dr. K.H. Vasudev Naidu Garu from SV Medical College, Tirupati. Dr. Srinivas Reddy Garu from William Harvey Hospital, Ashford, Kent, United Kingdom. Dr. G. Harnath Garu from William Harvey Hospital, Ashford, Kent, UK. All the resource persons readily accepted our invitation in spite of their busy schedule and shared their expertise on COVID-19. Thank you once again. I thank all the participants who enthusiastically participated in today's webinar. I thank Professor P. Sujata, Head Department of Bioscience and Sericulture, and my colleagues, Professor G. Savitri, Professor Nagalakshmi, Professor Dr. Vijay Kumari, Dr. Suvarnalata, Dr. Shanti Shri, Dr. Lakshmi Padmavati, Dr. Shobha Rani, Dr. Hemavati for their continuous support and encouragement in organizing this webinar. I extend my thanks.
There is only one question, ma'am, from Archana Batula.
Okay, just 1 minute, later it. I extend my thanks to Professor Venkatakrishna, Director Command Control Center, and technical staff members, Mr. Shyam Sundar, Mr. Tarun, Mr. Nagarjuna for the technical support in arranging the webinar. I thank the print and electronic media for the coverage of the webinar. Thank you and if there are any questions, you please ask me. Vijay Kumari.
Sir, there is query, sir, from Archana Batula.
Okay.
Dr. Harinath, sir. Can you hear me,
Yeah, I
sir?
can hear you.
how to handle a person with heart attack when hospitals are not attending immediate suspect COVID-19.
Sorry, can you just repeat the question because you're breaking?
How to handle a person with heart attack when hospitals are not immediately suspecting COVID-19.
So how to handle a patient with a catheter?
Heart attack, cardiac patient, heart attack,
Oh,
sir.
So I'm sorry, I'm still not able to catch you because you're breaking.
Sir, if a person has heart attack,
చెప్పు question.
sir, how to handle a person with heart attack when hospitals are not attending immediately suspecting COVID-19?
Attack.
Yes, sir. Yes, sir.
Wow. Okay. Well, I think that's beyond my talk. I that's I would say that's negligence. That's a negligence. And as I was preparing the presentation, I had a message from one of my friends saying that a healthcare professional has been referred to the regulator because he refused to see a patient who is COVID positive, and I believe he needed some intubation. So I think doctors, they have to carry out the duty. Full stop. And there's no way they can refuse a patient. Of course, this is not to do with the doctors, I suppose. It's to do with the hospital. So the hospitals are accountable. They cannot refuse a patient. That's against all medical ethics. You look at any angle, it's against medical principles, medical ethics, and against humanity. They might as well close the hospital.
Thank you, sir.
Thank
That's
you.
all, sir.
Okay. If
Thank
there
you.
are
Thank you
no
very much.
questions, I request all the participants to fill the feedback forms and send it today. And we will join tomorrow at 10 a.m. as per the program schedule.
Thank you. Bye-bye, everyone.
Thank you so much,
Bye-bye,
sir,
sir.
for joining us today. Thank you very much.
Thank you very much, sir.
We will wind up the program today and we will meet you tomorrow.
Okay, ma'am.
Okay. Thank you so much. Thank you, Vijay.
Thank you, ma'am.
Thank you so much.
Okay, ma'am. Bye, ma'am.
in Ukraine and రాసేసాను.